So imagine you have this physical injury,
Right.
and it's completely healed.
Right, like a muscle tear or a surgical incision or something.
Exactly. The cells have regenerated, the structural damage is just, it's gone. Physically, the area is flawless,
Hmm.
but you are still in this blinding, unending pain.
Yeah, which is incredibly frustrating for patients.
Right. And it's happening because your central nervous system has actually structurally rewired itself to permanently feel that initial trauma. So, I mean, the hardware is fixed, but the software has, well, it's basically rewritten its own code to permanently run a virus.
That's a really good way to put it.
And that is the maddening reality for millions of people who are suffering from chronic pelvic pain. So welcome to today's deep dive. We're looking at a fascinating medical intervention for this.
Yeah, the ultrasound-guided pudendal nerve block.
Exactly. And how it's actively being used to, intercept and break this exact agonizing loop in the lower pelvic canal.
It's a huge topic.
It really is. And for our sources today, we're pulling from the 2021 European Guidelines for Vulval Conditions, some highly detailed anatomical studies, and these breakthrough papers on pain desensitization algorithms from both the Society of Laparoscopic and Robotic Surgeons and the American Journal of Roentgenology.
Yeah, and medicine spent, literally decades treating pelvic pain by hunting for a broken organ.
Right, the old find the broken part strategy.
Exactly. The old paradigm basically dictated that, if the pelvic region hurts, well, the bladder must be failing, or the uterus,
Why?
or the prostate.
It had to be an organ.
Right. But the big paradigm shift happening across all of these clinical guidelines is this realization that we really have to abandon that organ-based model.
Wow, really?
Yeah, because the nervous system didn't just, report the disease. The nervous system actually became the disease.
Okay, so to understand how the nervous system turns on itself, we really have to trace the actual physical wiring.
We do, yeah.
And the focal point of the research today is this major electrical cable called the pudendal nerve. And just looking at the anatomical diagrams from our sources,
Yeah.
it looks like a structural nightmare.
The geography is absolutely brutal.
Right.
The pudendal nerve is massive. It carries both sensory and motor signals, and it originates right out of the sacral plexus.
Down at the base of the spine.
Exactly. Specifically the S2 to S4 spinal nerve roots. But the thing is, it doesn't take a direct, protected path to the pelvic floor.
It takes a detour.
A severe, highly exposed detour. First, it literally exits the pelvis entirely through this bony doorway called the greater sciatic foramen.
Wait, hold on. It leaves the pelvis
Yep.
just to supply nerves to the pelvic floor. That seems, like a massive design flaw. Why route the electrical cable outside the house just to plug in a lamp inside the living room?
I know, right? Evolutionary biology isn't always elegant. And by exiting the pelvis, the nerve immediately has to weave between these two massive, really dense bands of tissue.
The ligaments, right?
Right, the sacrospinous and sacrotuberous ligaments. Just picture a thick electrical wire being threaded directly through the blades of a heavy pair of scissors.
Oh, wow. That sounds terrible.
It is, because every time you walk or bend or sit, those ligaments shift.
So there's a constant shearing force.
Exactly. And after navigating all that, the nerve re-enters the pelvis through a second bony doorway, the lesser sciatic foramen.
So it's weaving in and out of the bone structure, rubbing against these massive shifting ligaments. And then it hits what the anatomical studies call Alcock's canal.
Right.
What exactly is that structure?
So it's a fascial tunnel, basically a really tight, narrow sheath of connective tissue clinging to the inner wall of the pelvis.
Okay.
And the nerve has to thread through this final restrictive tube before it can finally fan out to provide sensation and motor control to the perineum, the anus, and, the genitalia.
So visualizing this, it's less like a generic traffic jam and more like a thick garden hose being dragged tightly around a jagged corner and then, shoved under a heavy shifting door.
That is exactly it.
If the muscles pulling that door tighten up even a fraction of an inch, you pinch the hose.
And a pinched hose builds pressure instantly. Because of this twisting, weaving pathway through all that dense connective tissue, the pudendal nerve is incredibly vulnerable to mechanical entrapment.
Which creates a huge problem.
Right. It creates this specific agonizing condition called pudendal neuralgia. And the clinical hallmark of this, which is a major part of what doctors use for diagnosis, called the Nantes criteria, is fascinating.
Yeah, I was reading about that.
Patients experience severe pain that actively worsens when they sit down.
Because the physical act of sitting,
Hmm.
it compresses that exact real estate where the nerve is weaving through those ligaments and into Alcock's canal.
Right, exactly. You are putting the entire weight of your upper body directly onto the pinch,
Man,
and the pain often vanishes almost entirely when the patient stands up or lies flat because that physical clamp is finally released.
that makes so much sense.
And furthermore, according to the Nantes criteria, this specific pain rarely wakes patients from a deep sleep, and there's actually no objective numbness when a doctor examines the area.
The nerve isn't like dead or severed.
Right, it is just hypersensitive, trapped, and, screaming.
Okay, so the mechanical pinch part makes total sense. You step on the hose, the nerve screams, you take your foot off, it stops.
Right.
But the sources focus really heavily on what happens when that foot stays on the hose for months or, even years. The problem stops being strictly mechanical at that point, doesn't it?
It does. The mechanical entrapment actually initiates a biochemical cascade that alters the body entirely.
How so?
Well, this brings us to the core concepts of peripheral and central sensitization. If the pudendal nerve is constantly bombarded by noxious stimuli,
Like the tight ligament or scar tissue?
exactly, say a ligament is chronically tight, or there's pervasive scar tissue from a difficult childbirth or a pelvic surgery, the nerve itself becomes chronically inflamed. That is peripheral sensitization.
Okay, peripheral makes sense.
But the real the reason this condition is so notoriously hard to cure, happens centrally, up in the spinal cord.
Wait, unpack centrally for a second. Are we talking about the brain literally changing its structure?
Basically, yeah. The process starts at the dorsal horn of the sacral spinal cord. This is the crucial relay station where the pudendal nerve hands off its physical pain signal to the central nervous system so it can carry it up to the brain.
Okay, I'm with you.
Under normal, healthy conditions, you get a pinch, a signal goes to the dorsal horn passes it along, and your brain registers pain.
So it's a one-to-one translation. The input matches the output.
Exactly. But when that signal is a relentless 24/7 barrage of agony for months on end, the dorsal horn becomes overwhelmed by the traffic.
It just gets flooded.
Right. And to cope with that barrage, it physically and chemically alters itself. Medicine refers to this as a nosoplastic change.
No, it's a plastic. I know.
The pain receptors at the relay station literally multiply and become highly reactive, so the central nervous system actively upregulates the signal.
Wow. So instead of a one-to-one translation, the spinal cord is turning a volume knob from a 2 all the way to a 10.
Exactly.
So the trapped nerve in the pelvis might just be sending a mild discomfort signal at this point, but the spinal cord amplifies it into blinding agony
Right.
before it ever reaches the brain.
Right, it becomes this terrifying exaggeration phenomenon. And this is the ultimate tragedy of chronic pelvic pain.
Because the original problem might be gone.
Exactly. A patient might undergo a highly successful surgery that completely removes the original entrapment. The foot is entirely off the hose, so to speak.
Yeah.
But because the dorsal horn has undergone permanent nosoplastic changes, it just continues to spontaneously generate massive pain signals.
That is completely wild. I mean, you could go to dozens of specialists, get MRI after MRI, and they keep telling you your pelvis is completely fine, everything looks normal.
And they are technically right about the local tissue,
But they are entirely missing the fact that the spinal relay station is basically fried.
because they are looking for a structural disease in an organ. They aren't looking at the nervous system's altered processing. And to compound the misery, the pelvic floor muscles respond to this phantom pain by doing what muscles naturally do when you're hurt.
They tense up, right, to guard the area,
Exactly, they clamp down.
which physically clamps down on the pudendal nerve all over again, restarting the actual physical peripheral pain.
Yes.
So you are trapped in a totally self-sustaining loop.
Mm.
The false pain causes real muscle tension, which causes real structural pain.
The pain generators multiply and they just feed off one another. You have the upregulated dorsal horn, the inflamed peripheral nerve, and the spasming pelvic muscles, all functioning as independent sources of agony.
This paints a pretty bleak picture for anyone dealing with this. I mean, if your spinal cord has permanently amplified the pain and your muscles are clamped down in defense, you can't just stretch that away.
No, definitely not.
You need something that fundamentally interrupts the biochemistry, right?
You have to engineer a profound interruption. And that is the foundation of the pain desensitization algorithms outlined in the surgical and radiological papers we looked at.
Okay, so this is where the nerve block comes in.
Yes, the primary weapon here is the ultrasound-guided pudendal nerve block. And the objective isn't merely to numb the pain for an afternoon so a patient can, rest.
Right, it's not just a Band-Aid.
No, the objective is to physically intercept the noxious stimuli to force the dorsal horn to stand down.
Break down the actual chemistry of this block for us. Like,
Yeah.
what exactly is going into the tissue to force a neurological shutdown? Because the sources list a very specific cocktail of medications.
They do. A standard algorithmic approach uses a multi-stage mixture. So first, a physician will inject a fast-acting local anesthetic like 1% lidocaine.
Okay, lidocaine.
Yeah, and this knocks out the pain transmission almost instantly, providing immediate relief. But lidocaine metabolizes pretty quickly, so it's paired with a longer-acting anesthetic like 0.5% bupivacaine. This acts as a bridge, keeping the nerve quiet for several hours to days.
So you get an immediate mute button followed by an extended hold. But anesthetics inevitably wear off. Where does the long-term repair actually happen?
That's where the critical third ingredient comes in. A corticosteroid, typically dexamethasone or triamcinolone.
Okay, steroids.
Right. While the anesthetics silence the electrical transmission of the nerve, the steroid goes to work directly on the peripheral sensitization. It radically suppresses the local inflammation around the nerve sheath itself.
Wait, how does quieting the local nerve fix the software bug up in the spinal cord? If the dorsal horn is already upregulated, doesn't it just keep firing its amplified signals regardless of what the pudendal nerve is doing down in the pelvis?
That's the genius of it. The dorsal horn actually requires constant incoming noxious input to maintain its upregulated nosoplastic state.
Oh, really?
Yeah. By bathing the pudendal nerve in this specific cocktail, you create total radio silence. For the first time in perhaps years, absolutely zero pain stimuli reach that sacral relay station. And when it's entirely deprived of that input, the central nervous system begins to downregulate. It recognizes there is no structural fire anymore, so it slowly stops sounding the alarm.
So it physically prunes back those extra receptors
Yeah,
because they aren't being used anymore.
exactly.
It's not just pain relief. It's literally a biochemical reset button for the spinal cord.
It really is. And, beyond the therapeutic mechanism, this block serves a vital diagnostic function within the Nantes criteria we discussed earlier.
Oh, right, because if it works, it proves what the problem is.
Exactly. If a patient is lightly sedated and the physician administers the block directly at Alcock's canal and the patient wakes up to find their chronic pain instantly eradicated,
Then you know for sure.
it proves unequivocally that the pudendal nerve is the primary conduit. You have successfully isolated the faulty circuit.
That's incredible. Well, let's talk about the logistics of actually hitting that circuit.
Okay.
Because you're trying to inject a highly specific cocktail directly next to a nerve the size of a spaghetti noodle. And it's buried incredibly deep in the pelvis, surrounded by major arteries and veins.
A very tight target.
Yeah. And one of the papers from the American Journal of Röntgenology showed that using a CT scan to guide the needle had a 96% success rate in achieving perineal analgesia in their study group.
Which is fantastic.
96% is staggering. So why on earth are the newer algorithms pushing for ultrasound instead of CT guidance?
Well, the shift to ultrasound comes down to the grim realities of treating chronic pain. To achieve long-term downregulation of the dorsal horn, a patient rarely receives just one block.
Oh, I see.
The algorithm often requires a series of injections, perhaps 3 or 4, spaced several weeks apart. And CT scans rely heavily on ionizing radiation to create their images.
Ah, okay. So blasting the pelvic region with radiation repeatedly over a couple of months just to guide a needle, that's an unnecessary biological risk if there's a cleaner alternative.
Precisely. Ultrasound uses high-frequency sound waves, meaning there is zero radiation exposure. However, there is a massive clinical advantage to ultrasound that goes far beyond basic safety.
Which is?
Well, CT imaging is phenomenal for visualizing bone structure. It allows a radiologist to navigate perfectly to the bony landmarks of the ischial spine. But bone isn't the problem here. Soft tissue is the problem.
Right. The muscles in the fascial canals are what's doing the trapping. So ultrasound can see the soft tissue mechanics better.
Considerably better. And crucially, it sees it in real time. Physicians can use ultrasound to identify myofascial trigger points, or MTRTs, directly within the pelvic floor muscles.
Wait, how does a tight muscle not actually show up on a sound wave monitor? Like, what is the doctor visually looking for on the screen?
They look for focal hypoechoic regions.
Hypoechoic.
Yeah. In ultrasound physics, hypoechoic means the tissue absorbs the sound waves differently, making it appear as a dark, distinct mass compared to the lighter, healthy, striated muscle around it.
That is so cool.
And it gets better. Advanced ultrasound setups even use vibration sonelastography. The doctor introduces a minor physical vibration to the tissue, and the machine measures how the tissue ripples in response.
Oh, wow. So a stiff, cramped muscle knot isn't going to ripple the way a relaxed, healthy muscle does. It's going to be rigid.
Exactly. It displays significantly reduced vibration amplitude. Because of this technology, the physician isn't just, flying blind toward a bony landmark.
Right.
They are actively mapping the hypertonic, spasming muscles that are actually strangling the nerve.
That level of precision is wild.
It allows them to navigate the needle directly into Alcock's canal, meticulously bypass the internal pudendal artery, and bathe the exact specific site of the soft tissue entrapment.
Okay, so we've delivered the payload. The anesthetics silence the nerve, the steroids cool the inflammation, and the dorsal horn begins to power down.
Yep.
But the desensitization sources are incredibly adamant about one detail. You do not just send the patient home to celebrate.
Definitely not.
The block is just phase 1, right?
Right. The block is merely a window of opportunity. It does not replace the rest of the algorithm. If a physician stops at the injection, the pain will almost certainly return once the medications fully metabolize and clear the system.
Because you haven't actually fixed the heavy door sitting on the garden hose.
Yeah.
The muscles are still structurally prone to clamping down the second the nerve wakes up.
Exactly. And when the pelvic muscles are locked in those severe spasms we saw in the ultrasound, they create neural ischemia.
Which means?
They physically choke off the blood supply to the pudendal nerve. Nerves require massive amounts of oxygen to function and heal. When you strangle the blood flow, the nerve suffers ischemic damage, which fuels even more neurogenic inflammation.
But the nerve block breaks the muscle spasm temporarily.
Yes.
So the tissue finally relaxes and oxygen-rich blood rushes back into the nerve to repair the sheath.
Which creates a narrow golden window for pelvic floor physical therapy. According to the algorithms, the patient needs to be in a specialized physical therapist's office within 7 days of receiving the injection. Ah, I see. Because for the first time in perhaps years, the therapist can actually manipulate the patient's pelvic floor without the patient's nervous system screaming and fighting back.
Exactly. The physical therapist is executing a structural cure while the nervous system is temporarily offline. And this goes far beyond basic stretching.
What are they actually doing?
Well, the protocols call for visceral mobilization to release deep tension around the pelvic organs, and diaphragmatic breathing to fundamentally change how the patient manages intra-abdominal pressure so they stop pressing down on their own pelvic floor.
One technique in the sources that really caught my eye was nerve gliding.
Oh, yeah.
That sounds like you are physically flossing the nerve through the tunnel. How does a therapist glide a nerve that's buried that deeply in the pelvis?
Through internal manual manipulation, they are doing exactly that, flossing the nerve. The pudendal nerve needs to be able to slide a few millimeters back and forth through Alcock's canal and between those massive ligaments as you walk, sit, and bend.
If the nerve is adhered to the surrounding tissue by surgical scar tissue or chronic muscle tension, it stretches and tears instead of gliding smoothly.
But while the nerve is completely numb from the block, the therapist manually works the surrounding tissue, stretching the fascial restrictions, forcing the nerve to slide freely again.
Yes.
They are physically untangling the cord.
They are restoring the mechanical integrity of the pelvis while the brain is busy unlearning the chronic pain. You are treating the peripheral entrapment and the central sensitization simultaneously.
Which is why the multidisciplinary approach is absolutely mandatory.
100%. A surgeon cannot solve this alone with a needle, and a physical therapist cannot solve this alone against an upregulated, hyposensitive spinal cord.
It requires a complete abandonment of the old ways we looked at medicine. I mean, we started today looking at the brutal geography of the pudendal nerve, right? A major cable forced through shifting ligaments and tight, bony doorways. And we examined how a simple physical entrapment can just hijack the spinal cord, forcing the dorsal horn to rewrite his own biology into an endless loop of amplified agony.
It's a terrifying loop.
And we saw how the precision of real-time ultrasound allows doctors to hunt down stiff, dark trigger points, deliver a chemical reset button to the nervous system, and carve out a pain-free window for physical therapy to actually fix the underlying structure.
It really moves us away from an outdated, organ-based disease model to a system-based healing model. By separating neurogenic pain from structural mechanics, we can intercept the signals at their source rather than just masking the symptoms with systemic painkillers.
Which leaves us with a truly fascinating concept for you to take away. If a targeted ultrasound-guided injection can literally help the spinal cord unlearn chronic pain in the pelvic floor by forcing a biological downregulation of the dorsal horn, what does that mean for the rest of the human body?
It's a huge question.
Right. Could this exact same blueprint intercepting the signal to force the brain to rewrite its broken code be the key to unlocking mysterious, unsolvable chronic pain syndromes in the back, the neck, or the joints? If we can biochemically reboot the pelvis, what other chronic suffering is just waiting for the right reset button? Thank you for joining us on this deep dive.